Pericardiocentesis technique. The purpose of this section is to talk about how we use the anatomy and the different tools at our disposal to do the procedure. So these are generic points for how we use the equipment. So now we come on to pericardiocentesis technique. We've already carefully prepared and worked out the best approach for the pericardiocentesis. And we now need to carefully mentally note a number of different factors that we need to then remember when we start actually inserting the needle. And it's very easy to forget these things when you're busy trying to concentrate on the patient, on the monitors, and what your hands are doing. So it really does help to mentally rehearse and to keep in mind these different parameters. Remember that you've got 6 dimensions of movement. You can go forwards or backwards or upwards and downwards. You can go through sway and yaw and all the different movements that your needle can have. So you need to remember exactly the angle that you want to approach the pericardial fluid, because you worked out previously what the safest angle of approach is. And also remember that if you're pressing on the abdomen, you're going to potentially affect all of those parameters. So if, for example, you imagine if you're palpating the abdomen, imagine it's like not quite the same position. Unfortunately, I couldn't find a perfect photographic match for pericardiocentesis, but you can imagine that if you were trying to insert a needle here, the act of pressing into the abdomen will very much affect the actual angle that your needle can take and the need to go underneath the costal margin. So think in terms of the difference in position and angle when you're pressing on the abdomen as opposed to when you're resting a needle gently on the surface. When you're absolutely satisfied that you've got the right angle and you know what the depth that you're going to be aiming for is, you can then actually start the procedure. And I would urge you to scan before you drape the patient, but also sheath the probe and scan again, the last thing you do before you pick up your needle and syringe. The first thing is to infuse some local anesthetic, and I would do that to the full depth of the green needle. Then make a small skin incision. If you're using the pericardiocentesis needle, it won't go through the skin without the obturator, and it just is generally easier to have a small skin incision first. And I would urge you to have a two-handed technique. I'll show you more what I mean towards the end. Let's talk more about our needle options. We could use a standard needle which has got a longer break-in depth, and that means that the sharp knife bit of the needle is longer, and in practical terms it feels sharper. This also means that it has a greater break-in depth, so it has to penetrate further, maybe a millimetre or possibly more further than a short bevel needle, in order to allow us to insert our wire, which could be critical depending upon the depth of the pericardial effusion. These are close-up photos of the end of a standard needle. We use a Kimmel needle that we might use for putting in a venous sheath. This takes a standard guide wire. We need a smaller guide wire which is floppier and a little bit harder to control for the pericardiocentesis wire. Can you see the difference in size of the bevel with the short bevel versus the long standard bevel needle? If we're using a pericardiocentesis needle, we will need to use an obturator both to penetrate the skin unless we made a nick in it, and also to penetrate the subcostal fibrous tissue, and also to penetrate the pericardium. We can do it by pressing harder, but if we press harder, that isn't so controlled. Now, any benefits you get from the shorter bevel in terms of the break-in depth can be lost if you're not able to control it as well, because in practical terms it isn't as sharp as the standard needle. So there is a definite learning curve to a pericardiocentesis needle, and I would generally recommend a standard needle unless you need the extra length that's given to you by the pericardiocentesis needle, and sometimes you do need that, so you need to have an understanding of the differences. Let's look at those in a little bit more detail. So I would say a standard needle is easier to control, and that is a very important benefit if you don't do many pericardiocentesis procedures. It feels sharper because of the practical considerations of the shape of the tip. The longer bevel does mean that there is a longer breaking distance, and the larger needle means that this little knife tip on the end of the needle is longer. And it has a shorter reach than a pericardiocentesis needle, but these disadvantages are outweighed by the fact that it is easier to control because it's shorter and it's sharper, so you get through potentially tough fibrous tissues more easily. Pericardiocentesis needle, it's harder to control, as we've just said. Particularly it can be hard to keep the depth once you're in the pericardium. It can be very difficult to keep track of just how far in you are, and there's a tendency to drift further in. You have to use the obturator in order to use a pericardiocentesis needle. That means you can't aspirate, and that takes away one of the key bits of information about where you are. You could argue that the shorter breaking depth lowers the risk of cardiac damage, but in non-expert hands that benefit is lost and it's potentially more risky. But it does definitely allow you a longer reach when you are going subcostally and there's a lot of tissue between you and the pericardial fluid. Further important points are to think about how to change the needle track, how to change the angle that the tip is taking, the approach the tip is taking. This is the same for any needle, but it is much more significant for a long pericardiocentesis needle. Do not try and do it by moving the syringe. You're over 20 centimeters away from the thing you're trying to influence, and you will not achieve what you're aiming for. Instead, it's better to press on the middle of the needle or close to the tip of the needle to try and make it curve. And the further out you can withdraw the needle before trying to change track, the more success you'll have. A needle which is deeply in, you won't be able to change where the tip is going. Remember that there are tough fibrous tissues on the way through, and an obturator is essential if you're using a short bevel pericardiocentesis needle. And consider doing a little skin incision. The skin is often tough, and that's the point at which it's hardest to control the needle, so it's better to make a little incision in the skin than to do it at the end, although that is optional. What is very important is to use a two-handed technique, and I'm about to show you diagrams to explain all that I've just said and to explain why I think a two-handed technique is the best one. This is a CT scan of a patient with a pericardial effusion around the heart with the liver and the sternum. I've put it at a slight angle to reflect the fact that patients are usually on a wedge when we do pericardiocentesis. Can you see how little separation there is between the sternum and the liver? This would be a high-risk approach for transecting the liver and would not be recommended. How about an alternative? Lots of separation between the sternum and the liver. But here, if we take our 30-degree approach, you're actually going through a very narrow portion of the fluid. Actually, a steeper angle might be more appropriate in this example. This shows you how knowledge of the anatomy, gained principally with ultrasound, helps you to direct the procedure and not follow the basic rules. This is another example. Here, a pacemaker has caused the pericardial effusion. There's nice separation between liver and sternum, and we could simply go in at a 40-degree angle and get straight in with an excellent amount of depth there. Often there might not be as much fluid here, and the classic approach aims to have more of a 30-degree angle that allows us to have a greater depth separation by going more obliquely. If it's important to achieve our 30-degree angle, often by pressing down around where we're inserting the needle, we can get a centimetre or so down from the surface to help us with this 30-degree angle. But that's not always possible. And if we were to take a true 30-degree angle without doing that from the start, we would have to go quite a long way below the margin of the ribs. So very often in reality, we take a steeper angle. Now I'm going to exaggerate things a little bit from here on to make the point that I want to. So typically we go in at a 45-degree angle so we can be close to the sternal margin and get underneath it. And then we take a shallower track to get to the pericardial fluid. But this area is full of fibrous tissue and it's quite a tough area, and changing the needle track is not straightforward, and these factors are exacerbated by the length of the needle. So imagine the needle tip being in a kind of a vice grip, and if you then try to make the angle shallower simply by lowering the syringe, you get a nice 30-degree angle on the surface and pat yourself on the back, but actually the bit you can't see that's inside isn't any shallower, and if you advance that needle, it will actually potentially go an even steeper angle than before. So what do? Instead of lowering the syringe, we put pressure with our hand that's resting on the patient, pushing down the needle closer to the surface of the skin, roughly in the middle. The skin will stretch slightly, and that will push the bend of our needle down. The fact that you're much closer to the pace you want to move it means that you're much more likely to be able to change the track of the tip of the needle. And now the tip of the needle is going in at a 30-degree angle. We don't need to worry that our syringe is at a steeper angle. The bit that's important is obviously the bit that's inside the patient, but that's the bit that's hard to see and can be hard to appreciate. And you can see that we're going to achieve a nice shallow angle with maximizing our depth error margin. So I hope you've followed all those important points about how to control a needle, and these apply whether or not you're using a short bevel long pericardiocentesis needle or a more standard needle. How do you set it up? Well, we have our pericardiocentesis needle, the syringe attaches onto the end of it, and this is a crocodile clip which is attached to the metal part of the needle close to the hilt, and that will give us an endocardial signal. More on that later. This is an example I've got off the internet, and it's an example of how not to do it, because here look how long this obturator is in this pericardiocentesis needle. We have a hand that's doing nothing of any value. We have a needle that's inserted far too far into the patient, and we have everything being controlled by the right hand a long way from where the actual control needs to be applied. Another example from the internet, this time the pericardiocentesis needle is being held rather impressively like a dart, but again all the same concerns about your control and about how you're going to make that needle bend apply. This is not the right technique. Instead, this is the approach that I would recommend. Your left hand rests on the patient, and it rests with your knuckles down like this so that you can comfortably hold the needle between your thumb and your index finger. This hand doesn't move from the patient for the entire procedure. And this hand is the critical one for defining the angle of your approach, the pressure that you're applying, and it helps to keep everything rock steady because you're not floating in space, you are resting on the patient. Remember how long the needle is. One thing I like to do just before I actually insert the needle tip is to hold the needle at the point at which I want to insert it to. For example, to 5 centimeters, I'd hold it 5 centimeters from the tip. That then helps me to remember and to lock the distance that should be outside the patient when I've reached my desired depth. You do get some pericardiocentesis needles which have centimetre markings on them, and I do think that is a helpful measure when you have such a long needle. Do not move that hand from the start to the finish of the procedure. Your right hand is less important. It controls the syringe and puts the obturator in and out, or the wire in and out. Remember, you need to be using the obturator with the long pericardiocentesis needle. It does apply some pressure, but it's gentle, controlled pressure, and the control is through your left hand. It clearly doesn't control the angle. Remember to control the angle by adjusting the needle closer to the skin. These factors are much more critical with the long pericardiocentesis needle than they are with a standard needle, but the principles of control and how you control the needle tip are still relevant.